We're talking today about antagonist therapy for opioid use disorder. And here we go. The accreditation statement for ECHO, and I have no disclosures for today. Briefly, we're going to review the definition of opioid use disorder, and then we're going to jump straight into the mechanics of using antagonist therapy for treatment. We'll talk about the mechanism, side effects, contraindications. We'll review the evidence, and then actually walk through the logistics of administration and how antagonist therapy can be used in special populations and situations. I'm sure you're all familiar, but here are the 11 DSM criteria for opioid use disorder, of which you need at least 2, so they cannot be solely physical dependence as intolerance and withdrawal. You do need some indicators of social dysfunction and behavioral compulsion. The primary medications that we use are full agonist, methadone, a partial agonist, buprenorphine as either a mono product or combination product, and then the antagonists, oral naltrexone or injectable extended release naltrexone. As with any other addiction, behavioral health is an important component as well. So again, antagonist therapies really is talking about naltrexone, which is a long-acting synthetic opioid antagonist. It binds the central mu opioid receptors to block any agonist effect if someone were to consume an opioid on top of, while they already have naltrexone in their system. It has no agonist effects, but it does help reduce cravings. It has an extremely high affinity. It is the highest affinity for any opioid, and so it is very difficult, or it is difficult to overdose when on naltrexone. And it comes in 2 versions, as I was hinting at earlier, an oral tablet that is only in 50 milligrams, and it can be taken either once daily or 3 times a week. And naltrexone also comes as an injectable solution marketed as Vivitrol, which is a 380 milligram intramuscular injection given every 28 to 30 days, so 4 weeks or monthly. These are the primary side effects. So because of naltrexone's high affinity, if naltrexone is taken while any opioid is in the system, it will boot that opioid from the receptor, causing a precipitated withdrawal. Naltrexone can also cause mild transaminitis and rarely hepatitis. And I have on my slide here in parentheses oral naltrexone only. And that's because even though the packaging insert on Vivitrol references hepatitis and liver dysfunction, and some of the early trials suggested that was possible as well, more recently, the evidence seems to suggest that that really is limited to the oral version of the medication. And we'll talk a little bit more about that later. So other side effects include nausea, anorexia, vomiting, and diarrhea, insomnia, depression and anxiety, headache and dizziness, and then some people can experience a reaction at the injection site with pain, swelling, redness, or itching. And in that case, you might consider whether you're using a long enough needle to make sure the medicine is in fact deposited in the muscle. One other important side effect is that while someone is on an antagonist, they are losing tolerance to opioids because, again, it doesn't have an opioid agonist effect. And this means that if treatment with an antagonist is stopped, their tolerance is lower. And if someone were to use the amount of opioid they had previously, their risk of overdose is higher. Here are the key contraindications. So chronic opioid use with or without physical dependence, an anticipated need for opioid therapy, any situation in which there is increased risk of withdrawal, precipitated withdrawal, such as ongoing withdrawal, evidence of opioid in the system through urine testing, or if someone does a naloxone and naltrexone challenge and that precipitates withdrawal, then it is a contraindication to then go ahead and give the long-acting version. A naloxone challenge is usually 0.4 to 0.8 milligrams as an IM injection, though you can also give 25 to 50 milligrams of the oral tablet. The IM naloxone challenge will give you far more immediate results, whereas an oral challenge can take about an hour to really know if someone's going to experience withdrawal. And then hypersensitivity is a contraindication. So The evidence for oral naltrexone is actually fairly weak compared to extended release naltrexone and the other medication options for opioid use disorder. Oral naltrexone has higher rates of mortality and lower rates of retention. The outcomes are best in patient populations where the patient is highly motivated, for example, clinicians who could lose their license, patients who will be observed while taking it, and those who are legally mandated. Behavioral health interventions can help improve outcomes on oral naltrexone. This is one example of a randomized controlled trial adding intensive behavioral health therapy to naltrexone versus oral naltrexone alone. And this was a very comprehensive behavioral health program with contingency management, cognitive behavioral therapy, motivational interviewing, and network therapy. And while behavioral health improved retention at the 6-month mark, retention had still fallen to 22%, or 1/5 of the patients were still engaged in treatment. The biggest retention is obviously a major challenge with oral naltrexone. The evidence for extended release naltrexone is stronger. I realize I modified slides a little bit. There's the first one on your handout is basically a trial that established the efficacy of extended release naltrexone for relapse and retention, I believe. This trial here on the slide with Lee and colleagues, it was a randomized controlled trial comparing naltrexone with usual care being community referrals. And this was in the population of individuals who had opioid use disorder or a history of, and had recently been released from a controlled setting such as jail or prison, or were in ongoing supervision. And they found that extended release naltrexone increased the time to relapse from 5 weeks to 10 weeks. The last two trials here compare extended release naltrexone to bupe-naloxone, and Tanum's group found that the IM naltrexone was non-inferior in terms of retention and treatment, and then as well as with reported opioid use from the patient and objective opioid use through urine testing. Lee and colleagues found a similar outcome. So this was a randomized trial comparing IM naltrexone to bupe-naloxone at 8 different inpatient detox sites, followed by transition to outpatient care. And they found that in the overall sample, the extended release naltrexone group had a lower rate of initiation, 72% versus 94%, and a higher relapse rate, 65% versus 57%. But it was that it was the relapse rate that explained the lower initiation rate. So that if they just looked at patients who made it to their first naltrexone injection, then the relapse rates were actually not significantly different. So these really high quality studies suggest that naltrexone, or IM naltrexone, is a really strong option or a good alternative to agonist therapy with bupe-naloxone. So who is the kind of ideal patient that might benefit from naltrexone therapy or IM naltrexone therapy? Those with a contraindication to agonist therapy. There are not a lot of people in this group, but there are certain clinical situations, for example, someone who has not been able to reach receptor saturation on Suboxone, and so they're on methadone and experiencing a side effect like QT prolongation. Someone who's had an inadequate response to agonist therapy, someone in a restricted living situation where agonist therapy is not allowed, for example, prison or certain recovery settings, and particularly useful prior to reentry, so before someone leaves a controlled setting. Prescribing and administering IM naltrexone can help minimize risk of overdose after leaving. Another situation is after a period of prolonged abstinence when tolerance is down and there's no physical dependence anymore, making agonist therapy less appealing or less kind of appropriate. And then in the setting of co-occurring opioid and alcohol use disorders. So the logistics of actually giving extended release naltrexone. So the first thing you have to do is order it, and you should order it prior to dosing because you do have to get it on site and then confirm that there isn't a prior authorization required by the patient's insurance. You should keep it refrigerated and then warm it 30 to 60 minutes prior to injection. There's a recommendation or standard to get a urine drug screen at baseline and and later doses if it's been over 28 days since the last injection. And then coming back to this concept of whether there is a risk for liver dysfunction, with oral naltrexone, we certainly get baseline LFTs and then serial monitoring. But SAMHSA had a statement in 2016, and then the Providers Clinical Support System had one in 2014 and 2018, actually saying that you don't even need baseline liver function testing with IM naltrexone. And I'm really curious to hear what people are doing in their practice, because this was a learning point for me when I was doing the research for this presentation. Obviously, if someone presents and they have a clinical concern, clinical suspicion for hepatitis, then you should be getting LFTs, or if someone has a pre-existing liver condition, that might be someone where you get baseline transaminases as well. Either way, ASAM has a recommendation not to withhold treatment while waiting for labs. You should feel confident starting and giving the first dose of extended release naltrexone, even if you don't have recent LFTs. If you do get LFTs and those are above 5 times the upper limit of normal, then there is a contraindication. And if you're going to monitor every 3 months at most is sufficient. And that is even for patients who have a comorbid condition affecting liver function like hepatitis C or other comorbidities like HIV. So more logistics. These are just snapshots of a publicly available online PDF of the algorithm for going through and giving IM naltrexone. So, and I don't think this one is in your handout, but I had a time last night to kind of blow up the main algorithm to make it a little easier to see in the presentation. So the first step you do is gather recent opioid use history. What is the patient reporting they've been using in the last 1 to 2 weeks? Then you go to urine drug screen. And between those two pieces of information, you can place them on an algorithm. On the left, you'll see the top red box says no use in the past 10 to 14 days. If that's what the patient says, and then they show no withdrawal symptoms and their urine drug screen is negative, you can go ahead and give the first injection. And all the way on the right, the patient reports that they have used opioids within the past 7 days. Then you should just go ahead and postpone the visit and the treatment until they are at least 7 days from their last reported use. If they fall in this middle ground of 7 to 14 days, so they haven't used in the last 7 days, but they've used within 14 days, then you can administer a cow scale or the clinical opioid withdrawal scale to see where they're at. And at a 4 or less, plus a negative urine drug screen, you could administer a naloxone or naltrexone challenge. And if there's no precipitated withdrawal, feel confident about giving the extended release naltrexone injection. However, if their COWS is above 4, then you would want to just symptomatically treat their withdrawal symptoms and see them back in 1 to 2 days to consider the first injection at that time. So just a few more details. It's a gluteal injection. You want to make sure the needle is longer than the depth of the adipose and sub-Q together. Usually a needle that's 1.5 inches or 2 inches in length is adequate. You want to alternate injection sites between injections and then observe for 10 minutes after injection for any adverse effects, either a local reaction, hypersensitivity, or withdrawal. You should be giving all of these patients medication safety cards and a bracelet so that in the case of an emergency and the patient is unresponsive, providers are aware that the patient is on antagonist therapy. A few notes about special situations. So if you're transitioning someone from buprenorphine, be aware that precipitated withdrawal is possible up to 10 days after cessation. And with methadone, it's actually possible up to 14 days. The recommendations are to wait 7 to 10 days and maybe to do a naloxone challenge, but just be aware that that withdrawal effect is actually possible for even longer. If you're transitioning someone from XR naltrexone to buprenorphine or methadone, then you should wait at least 1 day for the oral version or 30 days for the XR version. And that's because it'll be really hard to assess what the appropriate dose is if antagonist medication is still on the receptor. So you might inappropriately give more buprenorphine or more methadone than is needed because the naltrexone is still there blocking the effect. And then you also want to start really low because during the period of treatment with naltrexone, that patient has likely lost tolerance to opioids. A few more situations. 28 days after the last injection, if it's been longer than that, again, consider naloxone or naltrexone challenge. For chronic pain patients, this may not be the right therapy, and you might want to revisit the idea of agonist therapy. In pregnancy, if the patient is already stable on naltrexone, you can continue the medication. There is recently there have been recommendations that without strong evidence, without any evidence really to confirm that naltrexone has risks for fetal health, that you can continue naltrexone as an agent in opioid use disorder. You can also transition them to Subutex or buprenorphine, or you can discontinue medication altogether, though that is less recommended. And then finally, preoperatively, with oral naltrexone, you should stop 1 to 3 days prior to surgery. And with XR naltrexone, stop 30 days prior to surgery. So in conclusion, XR naltrexone is as effective as agonist therapy for opioid use disorder in preventing relapse. Is also well tolerated. The biggest risks of XR naltrexone is relapse prior to getting on that first dose, and the risk of overdose with treatment cessation when someone's tolerance has decreased. Particularly, the particular populations in which this might be useful are those with an inadequate response to agonist therapy, those in restricted living situations, those with co-occurring opioid and alcohol use disorders, and after periods of prolonged abstinence. Any questions?
All right, thanks so much for putting that together for us, Alyssa. Really appreciate it. I haven't seen questions pop up in the chat boxes yet. You can send them there or unmute and ask your question.
I have one question. Is there any evidence or any cases in the literature of patients who are on IM naltrexone and come in and need emergent surgery?
So the guidance out there around that, and I don't know, Dr. Bhatnagar probably has a lot of experience with this too, is imperfect, but basically the recommendation, not based on any sort of rigorously designed scientific study, is essentially that needs to be overridden, and that the way that will likely happen most efficiently is with the use of higher potency opioids like fentanyl. But it is a bit of a balancing act. That's the recommendation of which I'm aware. Yes, Dr. Bhatnagar says yes, fentanyl, and recommends ICU setting. So yeah, because that dosing can be fairly unpredictable, can be sorts of doses which nurses and other providers are particularly comfortable. So just is something that requires a different level of monitoring and care. Are there good question. Are there protocols for acute management of patients who may be subject to a test for precipitated withdrawal? So, if Dr. Bhatnagar is still on, she might chip in on this. The withdrawal precipitated by the naloxone challenge is fairly short-lived, 30 to 60 minutes. And so with appropriate supportive care, if typical comfort medications are readily available, that can be done. In the setting of acute precipitated withdrawal that had been precipitated by Vivitrol, that gets to be a little more tricky, right? And that's why, if the situation is at all unclear, we recommend that sort of challenge where the duration of those uncomfortable symptoms are briefer. But again, if it does happen, the higher potency opioids are more likely to overcome it. Again, either fentanyl or even parenteral buprenorphine, having the higher receptor affinity can overcome that. And Dr. Kellum chipped in with a recent experience as well. Had this happened recently? Patient transferred care here for naltrexone, proceeded with the XR without waiting for LFTs, and then they were greater than 5 times normal. What now? So it sounds like the question is related to the LFT elevation potentially. And so, closer monitoring, certainly. There's really fairly minimal risk, as Dr. Tilhou pointed out, of the injectable naltrexone exacerbating that, but certainly something that should be monitored closely, within a week or two, after that's been administered. We've had people at the VA get IM naltrexone after 5 days and then be told that they'll feel like they have the flu for a few days. Okay, that was from Dr. Bhatnagar.
So if I can chime in about that.
Yeah, absolutely. Thanks.
It's something that I wonder if it only is tolerated in the veteran population, but it's something that is effective if you think about the risk of relapse versus the risk of feeling not great for a few days. And I think that's how they get through the informed consent part of it and just say that these are people who've been struggling for a very long time, and they may feel crummy for a couple of days, and we can support them through that with the usual comfort medications. It's not my body that's happening to. I don't know if I would go along with it so willingly, but it seems like, and maybe Dr. Tilhou can speak to this, having gone through there a little bit more recently, but it is something that I had heard about as becoming somewhat routine and just trying to help people through that incredibly challenging 7 days of no use to get them onto the naltrexone. One thing I didn't see was the mention of use of low-dose naltrexone, which I just used with a patient here who had been struggling for a couple of months to get off of IV heroin, and we were successful. He just called me today. He was supposed to try to get his injection today, and he said no, he had to take it a little bit slower, but basically using no opioid for a day, and then starting the clonidine patch the day of his last use, basically, so that it catches up and helps him through that week. And then using 1 8-milligram film of Suboxone the third day, so second day after use of last use, and then using low-dose naltrexone the day after that, like 0.5 milligrams or 1 milligram. And then increasing as tolerated up to the 3 milligrams the day before his injection. So I just finished talking to him right before I got on this call, and he said that he had a very little bit of nausea with the 1 milligram and found it tolerable and is ready to keep going with that because it wasn't anywhere near what he expected, having gone through the withdrawal and transition before in the past.
Oh, that's great. Thanks a lot for sharing that. Yeah, we're definitely getting more inquiries around the low-dose naltrexone. So really appreciate you sharing that experience because, that's definitely something we're getting more questions about. Dr. Kellum and Dr. Egan had a couple more questions for those who can stick around because I know we're over the hour. Dr. Egan made mention of the fact that there are a number of settings where we don't have access to point-of-care urine drug testing. And so asking a little bit about the approach of others when that's the case. If you work in a setting without that, are you doing urine drug screen the day prior or skipping and more likely doing a challenge? We've handled that a variety of ways in our setting. I think, of course, common sense giving folks careful counseling about the potential for precipitated withdrawal and the importance of an accurate history around recent use. But as your question sort of points out, the clinical utility of getting that urine drug test at the point of care, if you don't have access to that information immediately, presents a challenge. So in our practice, we have not necessarily been getting that on the day of the Vivitrol injection, but in the context of collecting history, yes, gathering that data can be helpful in terms of discerning what's happening around recent use. But yeah, the point of care test is definitely helpful when you have access to it. Dr. Kellum also asked, have you ever had someone say they felt those flu-like symptoms for the entire month after a Vivitrol injection? And I have not experienced that or seen report of it. I don't know if others still on with experience with Vivitrol would say otherwise, or if they've seen that in their practices. I'll give that a minute. Maybe some of that will come up in the chat.
Yes, this is Ritu. I have had people say that. I had one person really struggle for a very long time with the withdrawal symptoms, and they said it felt like the prolonged precipitated withdrawal, sort of. I don't know that it would have precipitated anymore, but they had read about the prolonged withdrawal phenomenon, and so really felt like that was something that they struggled with. So we tried it for another month beyond that and really just provided comfort medications and additional anxiety medication support, but ultimately, if I remember correctly, that person didn't want to continue with it because it just felt too miserable for them. So, and unfortunately, I have to go now, but thanks for the conversation. It's very stimulating stuff.
Great. Thanks so much, Ritu. One experience I did have that was somewhat unusual was a patient who had been receiving monthly Vivitrol injections for over a year and then had been doing quite well, felt quite stable. And then at 5-6 weeks out from her last Vivitrol injection was reporting symptoms that felt like opioid withdrawal to her, which I still don't have a good explanation for. Let's see, and then we have Hometown Pharmacy takes a lot of compounded naltrexone prescriptions. So we got a couple comments around local resource Madison. I mean, if others outside of Madison have access to the low dose naltrexone and can throw that in the chat box, that'd be great. But yeah, Hometown Pharmacy locally here in Madison, Hoey Apothecary is another resource that's really familiar with doing that. And Dr. Tilhou asked about insurance coverage. No, but cost, I can't say I recall. And our best resource on that, Dr. Bhatnagar, who has quite a bit of experience with it, has just dropped off. I don't know if others know sort of about the cost related to that.
$40. It's about $40 up north. We have access.
$40 up north. Sounds like that was Sheila. Thank you.
Yeah, and I think I've seen like 50, but it depends on the dose.
Okay.
$50 in Madison.
The other practical thing I was going to mention, this is Sheila, given the incredible expense of the injection, we have consistently gone with initiating with the oral, the low dose oral, and walking them up over a few days, just to make sure that the $1,300
right
on site. Because even with prior auth, there's still an impact to the clinic if the patient ends up not taking the dose. So that's just a practical consideration.
Right. Great. Any thoughts from the group about this idea of early initiation on day 5 in the outpatient setting with counseling to the patient about withdrawal symptoms? Do you have others in the group have comment on that? That's something that we've talked about in our own practice when we have someone in front of us in the clinic. We have Vivitrol through our on-site pharmacy, and we're a little inside that 7-day window. In our own practice, that is something where we will occasionally get the naloxone challenge done, and if that goes well, move from there. But I don't know if others practice differently or have a similar experience as far as that goes. All right. And it looks like the chat flow is slowing down. So, and I know, let's see, from Vincent, it's a little concerning, but I do know there are some protocols for fast initiation with supportive withdrawal meds, gabapentin and others. So from Vincent.